Então, pessoal, eu sou Marcelo Lopes, eu sou diretor de ensino e pesquisa da DaVita, tratamento renal. Estou aqui com o Dr. Bruno Zawadzki, que é o diretor médico nacional, né, e organizador aqui dos nossos encontros mensais, né, nossa sessão nacional. Então, Bruno, antes de apresentar o nosso convidado, fique à vontade aqui para conversar com o nosso público.
Pessoal, boa tarde, obrigado aí mais uma vez pela presença. Hoje a gente vai ter essa sessão aqui extraordinária com o professor Ronco e agradeço aí a todos também por estarem aqui nos prestigiando. So, Marcelo, I think we have
we have a nice forum
a
right
full
now.
house here.
Yeah. And I think we'll have more guests joining while the
Yes.
meeting is going on. So
Let's
I want
start.
to thank in behalf of DaVita Kidney Care Brazil. I know this is as going on also as a grand round for DaVita International as well. So it's a great pleasure to introduce Dr. Claudio Ronco, who's a senior professor at DMed University of Para, Italy. He's also a director of international renal research at the Institute of Vicenza, and also he's from the Department of Nephrology, Dialysis, and Transplantation at the San Bartolo Hospital in Vicenza, Italy. He'll give us a talk about acute kidney injury and innovations. And please, Dr. Ronco, the floor is yours. Thank you so much for being with us at DaVita Brazil, and we're very excited to hear your presentation. And feel free to get us started.
Okay. Okay, so thank you very much for the kind invitation. I will spend some minutes with you speaking about what's going on in AKI. Now, years ago, we have been raising awareness about AKI as a silent killer. And actually, a few years ago, with the 0 by 25 initiative, the snapshot published in The Lancet showed that AKI is a common situation across continents with incidence between 15 and 30%, depending on how you measure it. And in fact, the incidence depends also whether you look for cases that need dialysis or simple AKI, and in which kind of patients. Most of ICU patients, of course, display the highest incidence for AKI. There is an increased incidence of AKI due to increase of exposure, but also increase of susceptibility. And indeed, we have patients with increased comorbidities. We have increased aging of patients and kidney, and we have more iatrogenic intervention that in presence of increased risk and less renal functional reserve, increase the incidence of AKI. Pathophysiology of AKI is very different. This is a syndrome, and it depends very much on susceptibilities, which are part of demographic of the patient, comorbidities, and social environmental factors, and also exposures such as acute illness, major surgery, medication, etc. Now, in the past, we had different, let's say, definitions that were based on variation of creatinine. But in 2002, in Vicenza, we put together a definition called RIFLE that subsequently evolved into AKIN and finally in KDIGO, based on creatinine and urine output definition. And whether you define this as risk, injury, and failure, or you describe this as stage 1, 2, and 3, the increased severity includes an increase in mortality, hospital and ICU length of stay, costs, and less recovery. Now, we know now that stages are dependent on variation of serum creatinine, but what is happening before the classic delta 0.3 milligram per deciliter of creatinine occurs? And indeed, we know that when from normal epithelium you have ischemia, reperfusion, toxicity, etc., Damage may occur in the cells well before there is an increase in serum creatinine, and therefore there are potential candidates molecules that may act as urinary biomarkers for an early diagnosis of AKI. We're now having biomarkers of damage, such as NGAL, dysfunction, cystatin C, or stress, like NephroCheck. And in any case, they allow us to build the so-called continuum of AKI that goes from a normal kidney to a totally dead organ, passing through an increased risk, stress, damage, dysfunction, etc. Before we hit the threshold of 0.3 milligram per deciliter, we may have conditions that we define subclinical AKI, which belongs in part to the biomarker domain, including the renal angina situation. This is important because biomarker positive patients, even if creatinine does not rise, have the similar dialysis or mortality endpoint and combined endpoint as patients with positive biomarker and increasing serum creatinine. So biomarkers are extremely important in this diagnosis, and we made recommendation on use of biomarkers at the University of Padova a few years ago together with the ADKI conference, and we included in the stratification the stage 1S, which is a stage where the serum creatinine has not increased more than 0.3 milligram per deciliter, but there is a positivity of a biomarker. Now, the new AKI KDIGO guidelines that just came out last week today divide the functional criteria and structural criteria and include biomarkers in the diagnosis. So we have functional criteria with serum creatinine and urine output, and structural criteria when we have damaged biomarker, and include the so-called stage 1S that now has become B1 positive, basically defining a new stage in AKI. Also, the guidelines distinguish transient from persistent AKI, having the limit of 48 hours for increasing serum creatinine and reduction on urine output. And also, they distinguish functional from structural criteria. Now, when AKI lasts more than 7 days and goes into AKD, there might be a complete resolution, or there may be a partial resolution. And among different functional outcomes, you may have normal GFR, but with normal or reduced renal functional reserve, and you may even evolve towards chronic kidney disease. We know today that from AKI, from no AKI, you can go towards damage, dysfunction, or both. And here you see the red arrows in this paper we published in Lancet a few years ago. This depends on risk modifiers such as inflammation, drugs, anemia, congestion, volume depletion, sepsis. But you can also have the blue arrows that may offer possibility of mitigation and intervention, optimizing volume, correcting inflammation, etc. And there are some specific mitigation measures suggested by KDIGO, depending on which stage the patient is, that have been applied in 2 studies. One is the PREVACI study, the other is the Big Pack 2 study, where basically Alex Zerbok and co-workers have applied this mitigation measure based on biomarker positivity. And they were able to reduce in the intervention group the incidence of AKI and severe AKI. In our own institution, we published several years ago in NDT, then when we applied the nephrology rapid response team and the use of NephroCheck as an early trigger for activation of mitigation measure, we could reduce the number of AKI in ICU and cardiac surgery, and also the number of patients requiring renal replacement therapy. So once you have a normal kidney or even a chronic kidney, you may have AKI, AKD, and there are several different trajectories. But today there is a great interest in the first 48 hours to distinguish between what we call transient and persistent AKI. Now, persistent AKI has increased mortality and has increased major adverse kidney events. And we have today a biomarker called CCL14 that allow you to predict which AKI is going to be persistent. Here you see that persistent stage 3 AKI have much higher urine CCL14 concentration compared to non-persistent. So we can have actually a diagnosis of this. And more than that, beside the stress and the risk for AKI with NephroCheck, the risk for persistent with NephroClear CCL14, we have today DDK3, which allow you to predict long-term loss of renal function. So using this biomarker and using this definition, probably definitions do not change so much in the management of day-by-day AKI, but they allow you to classify patients and stratify and use this for trials. Biomarkers, on the contrary, can be managed and become practical tool in everyday application of management of AKI. Why are they scarcely used? There are several different situations. People never end the search for evidence, but there is no question when is evidence enough. Sometimes the guideline was a recommendation alibi, but now biomarkers are in the guidelines. Then the cost, creatinine is cheaper, very true, but AKI is by far more expensive. Then there is poor knowledge, actually, of the AKI long-term consequences, the effect of subclinical AKI. Some people are wondering whether there is poor sensitivity or specificity. I think that basically the problem is the scientific inertia, and there are too many slothful physicians that don't want to use it. And our administrator use this as an alibi not to pay for biomarkers. Now, once you use the nomenclature, again, you may use the nomenclature to define AKD and also the progression to CKD, which may end up in recovery or death. Now, the recovery means that there is a complete resolution of the inflammatory infiltrate, while progressive scarring may occur if there is a maladaptive repair with collagen deposition. In particular, there is some kind of activation and G2M cell cycle arrest that induce what we call a premature aging of the cells and the so-called progressive scarring induced by endothelial to mesenchymal transition of different cells. Why is that important? Because people with AKI have 8.8 times higher chance to develop chronic kidney disease, and they have 3.1 chance to develop need of dialysis. So once you have a kidney attack and AKI, if you have complete recovery, it's one thing, but if you have a partial recovery, you may end up with a kidney with increased susceptibility. And in presence of risk factors, you may progress in the slippery slope of chronic kidney disease with chronic hypoperfusion, apoptosis, and finally sclerosis and fibrosis. Now, one of the interesting things is that many people may have an AKI where only partial damage to the nephrons occur. And if there is no complete damage, you may end up with what we call subclinical AKI. You need to have more than 50% of the tissue damage in order to have an increase in serum creatinine. Otherwise, what you lose is basically your renal functional reserve. And we made a study which showed how much the renal functional reserve before a cardiac surgery intervention has important in causing high risk to develop AKI. The most important observation in this study is that 3 months after a patient has developed AKI after surgery, there is a significant decrease in renal functional reserve, even though the baseline GFR has returned to normal. So when you look at the continuum of AKI and the recovery phase, you have to consider that full recovery is present when you have baseline GFR up to 90 or more and renal functional reserve completely intact. But apparent full recovery when baseline GFR is normal, but renal functional reserve is reduced. Now, concerning renal replacement therapy, KDIGO guidelines were a little bit conservative in the past. They said you should use it when it is needed. Today, there is a more clear, let's say, elaboration of the concept that the discrepancy between capacity of the kidney and demand from metabolic processes may have a discrepancy, and this leads to urgent indications or relative indication. To a certain extent, this is exactly the table that we published in 1994, Rinaldo Bellomo and myself, in the textbook Critical Care Nephrology. But today there is much more, let's say, consciousness on the fact that you should do a complete medical evaluation, and the process of starting should be a shared decision. And there is a recommendation to defer timing of renal replacement therapy in case of the possibility, as opposed to a strategy of early initiation, unless, of course, there is an immediate necessity of this therapy. Technology today can help in several points of AKI, from risk assessment, biomarkers, clinical diagnosis, indications, and then identification of therapy targets, help with prescription, delivery, and monitoring. And once you monitor the treatment, you may have a continuous decision to modify prescription in order to make adequate treatment. As you can see here, for example, guidelines recommend the volume of effluent between 20 and 25 milliliters per kilogram per hour, while originally we proposed 30 and 35. But again, they propose a dynamic prescription. And as you see up here in this small graph, if you have a climbing of urea with the standard prescription, you need to decide to reconsider your prescription and increase the amount of effluent, until you reach a breaking point where basically you're not under-dialyzing your patient. And also, there are patients that in different moments of AKI may require more or less treatment depending on how the metabolism and how the control of urea and other solutes is. Indeed, we have signals from the chemistry laboratory, from the patient, from the machine, that through the computer can go back with the biofeedback that can be fully automatic today. So technology tends to lead to physiological targets and assist with dynamic prescription in order to avoid derangement from the physiological target. We have machine today that, as you can see, can follow the prescribed and the delivery therapy and adjust the ultrafiltration and adjust the dose delivery based on the target desired. The problem of AKI is that very often in critically ill patients, this occurs in presence of systemic disorders and other organ dysfunction. An organ interaction may indeed lead to much higher mortality. Depending if you have 1, 2, or 3 organ failure, you see that the mortality ratio, the odds ratio, increase significantly. For this reason, more than renal replacement therapy, we speak about multiple organ support in critical illness and sepsis, what we call MOST. And this includes AKI in sepsis, liver failure, lung dysfunction, heart failure, and treatments that tend to modify these conditions. So the evolution of machines over the years, as you can see here, led today to the last generation of machines, which include hemoperfusion, and describe a machine which is much more a platform for extracorporeal organ support. Nomenclature harmonization is fundamental. We made several years ago the Carta of Vicenza and the Nomenclature Standardization Initiative Alliance has included several companies in order to define the names of the therapies from hemoabsorption, plasma filtration adsorption, CRRT combined, DP mass, etc. And we need to use a nomenclature harmonized in order to better perform our therapies. So what we call today precision MOST is a therapy that includes a different type of approaches for supporting different organs and coping with patient needs. Because there is a tremendous organ crosstalk from systems, organs, tissues, and even cells. And today, assuming that we have like cardiorenal syndrome, hepatorenal syndrome, pulmonary and kidney interaction, we know that by modifying the extracorporeal circuit, as you can see here, we can support different organs. But of course, we have to learn the interaction between native organs and also the interaction of artificial organs, because in many cases, some of them may interact, and some organ support, like ECMO, for example, may cause AKI or interfere with kidney function. Another innovation is the question whether there is a molecular signature for different types of AKI. Well, we had this cappuccino in Asiago, Italy, and we moved the attention from the classic symptoms, laboratory, biochemical, histological, to molecular and finally endotyping of patients, which include the approach of enrichment trials in order to get the specific therapy for each patient, for each characteristics. In other words, from a broad population with most pragmatic approach in which you can generalize very little, in most exploratory trials with a rich population, you can actually have a very invasive intervention, high cost intervention, but it can be actually possibly generalized to a specific group of patients. And in the sepsis-associated acute kidney injury consensus report, we identified the point that specific endotypes should be used to enrich clinical trial populations. So we know today that based on pumps, dumps, and different activation of pathways, we have different endotypes, for example, in sepsis. And this is a classic situation where you can apply different therapies. For example, you have ischemic toxic AKI, cardiorenal syndrome, cytokine release syndrome, hepatorenal syndrome, sepsis-associated AKI. All these different type of endotypes may require different therapies. And here you see the different circuits that today we can provide for these patients. We have indeed proposed to include hemoabsorption as a new horizon, a new treatment for sepsis and sepsis-associated AKI. And because in the past, very few trials have been positive, the possibility to enrich population of sepsis-associated AKI in which high level of cytokines are present. This may indeed suggest the application of extracorporeal blood purification techniques. As you know, from the insult, triggers may be pathogen or damage-associated molecular patterns that indeed are activating different pattern recognition receptors. This has been used to develop the trial of Euphrates and finally Tigris, where they enriched the population of patients with endotoxin activity assay between 0.6 and 0.9, and they were able to show a really different outcome in the population. The same we can do for patients with sepsis, viral infection, CAR-T therapy, hemophagocytic syndrome, where you have a disruption of the immune system because you have activation of the innate immunity and patient time to die with intractable inflammation, but also activation of the adaptive immunity when patient may actually die due to persistent immunodepression. At this point, we have hemoabsorption that allow you to reduce significantly concentration of both pro and anti-inflammatory mediators and also cytokines with the most recent sorbents. So the peak concentration hypothesis has brought the concept that non-specific removal of these substances may lead to immunohomeostasis because they remove more of the substances that in that moment have higher peaks, somehow reconstituting the correct immune response. And in fact, we see a reduction in both pro and anti-inflammatory mediators, so achieving a kind of protection of the endothelial function and supporting organ function. But there is also, beside the typical biochemical response with reduction of cytokines and improvement in hemodynamics with much lower level of norepinephrine requirement, there is an increase in the function of monocytes and responding much better compared to the previous situation. And in particular, one of the most important effect observed is the improvement in HLA-DR expression on the surface of monocytes, which means reconstituting the possibility to present the antigen. This is a typical case, for example, of a COVID patient admitted with a high inflammatory profile and pulmonary dysfunction, hypercoagulability, treated for 3 days with hemoabsorption, even in the absence of AKI, with hemodynamic stabilization and normalization of the inflammatory profile until extubation. So today we have actually in sepsis and sepsis-associated AKI define the endotype we're dealing with, and based on different protein signature, cellular function, miRNAs or metabolites and biomarkers, we may personalize the therapy with specific approach. We call this sequential extracorporeal therapy because in the early phase, we may want to remove the pathogen or endotoxin, while in the second phase, we may need to remove the cytotoxic effect of pumps and dumps. We have to be aware that these cartridges tend to be saturated around 4 to 6 hours, so it makes no sense to use them for 24 hours. And this indeed is a very important possibility to prescribe subsequent sessions, short session. In the interval, you can actually deliver antibiotics and other drugs, avoiding elimination of beneficial substances. When you design a trial for hemoabsorption, you have therefore to set up clear indication, select a population, identify subphenotypes, and define target effects, which can be biochemical, biological, physiological, clinical, and only at the end survival or mortality is the endpoint. But remember that mortality may be affected by other things, so you are mostly studying one point in the time course of the sepsis syndrome. When we study AKI, again, we look for different stages, and we look for patients in which cytokine release syndrome may induce hypotension and oliguria, or there is a clear status of inflammation. Not every patient with AKI should be treated with this. The hyperdynamic sepsis model is based on the fact that there is late or no creatinine increase in renal blood flow, decrease in GFR and urine output, and increase in cytokine. And oliguria is induced by cytokine-induced vasoplasia. So if you look at this as a situation in which damage has not occurred yet, and cytokine release syndrome is the base for oliguria, this represents a target of therapy. And that's why the treatment should be done early, for few sessions, but very early intervention. Now, all data have been now collectible thanks to the wireless and cloud storage revolution. And the simple data acquisition may help you to end up with an enormous amount of data in your electronic medical records. And here you see some of the parameters that can be actually recorded and stored. And this allows you, as the consensus conference of ADKI mentioned, to use this for quality control, making the typical circle of planning, operation, controlling, and intervening, and modifying the management. Now, the number of data available is increasing dramatically. How do clinicians make decisions based on this? Well, basically, we have big data, but today we have artificial intelligence that allow us to analyze and store the data in proper correlation, leaving the possibility for a conscious and strategic planning that also allow you to develop research. Basically, you know that when you have little cues, you may actually control the outlier. But when you have cues that represent 10 or 20% of the overall situation, you may need to change policy. And now we have artificial intelligence that I prefer to call enhanced human intelligence, analyzing large number of medical records and unveiling connection, models, correlation, and improving diagnosis, also going into more complicated situations such as machine learning or even deep learning, where there is a use of artificial neural network to reach accurate conclusion without any interference. And so the possibility to develop silico trial, which is basically a trial only based on large registries collected by different centers. What will the future hold for CRRT and echoes? Patient endotyping for enrichment trial is quintessential. CRRT optimization with integration of AI-driven technology, patient-centered care and precision protocols, new membranes, possibly new sorbent, functionalized, non-thrombogenic, possibly miniaturized devices, robotics, and even green protocols. Now, precision medicine is suggested in the evaluation of starting, stopping, and timing can be variable depending on capacity and demand. Now, more is better in terms of dose until a certain point where the curve of survival reaches a plateau, but dynamic prescription is recommended. Different modalities are available, and new technological advances, including AI, should help clinicians to optimize prescription and delivery. But the future is dependent on investment and multidisciplinary collaboration. Now, here is ADKI conferences that have been generated recently, creating what we call a generative knowledge. We are trying to create knowledge from the knowledge our experts already have. And this is where, in the pyramid of evidence, the case series and report and non-randomized trial or observational studies may be reaching an important level of evidence, because the optimal randomized controlled trials that we search for may be never performed or may not possible to be performed. What I want to close is an important point that I make on the new KDIGO, which is finally, they write what I asked for years. Guidelines are not intended to define a standard of care and should not be interpreted as prescribing an exclusive course of management. Healthcare professionals using this recommendation should decide how to apply them to their own clinical practice. So no administrator, no lawyer should use guideline to modify our decision. And one more thing, for those who say there is no enough evidence for this or that treatment, remember that we should not confuse when the guidelines say we do not recommend, because we are unable to recommend this based on the current evidence, we recommend not to. In other words, not recommending something doesn't mean that you should not use it, but you have to use it with consciousness. You have to use it for specific population in order to generate the evidence you are searching for. Otherwise, a miracle such as the Carpe Diem machine for neonates that we created several years ago would never see the light because there will never be enough evidence. So this is exactly what we need to do for our patient. And with this, I take the liberty to invite you all to the AKI and Critical Care Nephrology meeting in Vicenza, Italy, next June. Please register and join us because this is going to be a fantastic meeting. With this, I thank you very much for your attention.
Wow, what a wonderful presentation, Dr. Ronco. I really thought that you showed us like where we are at right now at our specialty and with the AKI, and also the roads to the future. So it was a very exciting talk, and I mean, it was a privilege for us here at DaVita Brazil to have you speaking to us. And I also want to point out that there is we have here in this meeting lots of colleagues from our global DaVita village from other countries as well. So I really want to show appreciation and thank you so much for being here. E também para todos que são de fora da DaVita também. Estou vendo aqui alguns intensivistas, né, e outros nefrologistas de outros lugares também. A joia? Dr. Roca, I know that you're busy and you're moving on to another meeting. So I really, really want to thank you so much for being present with us. And if I would like to ask you just one question before I let you go. I know with the brilliant mind that you have and as a researcher, but what question do you think we as nephrologists should be asking? I mean, what have we not achieved in terms of like research in the AKI that you might be maybe having an itch to get that answer right now?
Well, first of all, I want to say that in Brazil, I am proud to tell you that I have several fellows from my institution that came to Vicenza and spent their time there, like Thiago Reis, like Gabriela Guimarães, and others. And indeed, what we ask ourselves in our institute is always, are we doing enough? Are we spending all our effort, knowledge, curiosity to make progress? And the other thing is, are we modest enough to confront with other specialties and be able to share the knowledge? Our idea was to create the round table of science. Why a round table? Because there is no head table. There is no one who is on top of others. We need help of other disciplines. We need knowledge from other professionals. So we should always ask ourselves, are we really doing enough? That's the question.
Wonderful. Bruno, would you like to speak a few words?
Just say again, thank you very much for Claudio Ronco to be with us. Say to everybody to go to Vicenza course because it's very, very nice, very close atmosphere, and take a nice cappuccino there together with Ronco and their team. So it's a completely different course and very nice. So please, if you have the chance, go because it's very nice and of course a lot of knowledge you can have there. So just say thank you again, Claudio Ronco. It's a pleasure to be with us.
Thank you very much. Sorry, I have to run because I have another meeting just immediately after.
No problem at all, Dr. Ronco. Thank you again so much on behalf of DaVita Brazil. And hope you enjoy your time in Istanbul.
Take care. Right. See you in Vicenza.
All right. Yeah, see you. All right.
Bye.
Joia, muito bom, Bruno.
Marcelo.
Poxa, a gente fica muito, muito feliz, né, de ter uma pessoa, um nefrologista tão brilhante, né, assim, tão atuante na área dele e ainda, né, produzindo bastante conhecimento para a gente. E essa aula ele sintetizou bem, né, Bruno? Assim, tanto o que está nesse novo código, né, de IRA, quanto também o que é que a gente está correndo atrás de novas tecnologias, né, e novas práticas também na área de lesão renal aguda. Então, aquela tipo da palestra que você sai assim, pô, boa, vamos correr atrás aí, né, do conhecimento.
Isso aí, acho que foi muito
vamos
bom.
para frente.
Marcelo, só para a gente finalizar aqui, acho que dá um spoiler aí, pessoal, qual mês que vem, que a gente tem, qual é a nossa programação aí?
Joia. Então, mês que vem, a gente vai começar uma série, na verdade, de algumas palestras que são mais voltadas ali para a prática do nefrologista ali na clínica de hemodiálise, né? Então, o tema que a gente vai trazer vai ser sobre o nosso protocolo na verdade, o tema sobre ultrafiltração, que a gente tem até um protocolo publicado na DaVita. Então, a gente vai falar de ultrafiltração no cenário de crônico, né? Em breve a gente vai anunciar direitinho os convidados aí dessa palestra, mas aí, a partir desse mês, vai ser mais esses temas mais práticos aí. Então, vocês vão perceber que vai ser uma escolha voltada para o cara que está ali no dia a dia da clínica de hemodiálise e serviço hospitalar também.
Beleza. Show de bola, Marcelo. Obrigado aí. Agradecer mais uma vez aí a presença de todo mundo e vamos em frente, que aqui a gente não para.
Não para, Bruno, vamos em frente. Forte abraço aí a todos. Obrigado pela presença de sempre, nesse horário aí mais cedo, né? Então, foi um desafio. E aproveita o feriado de vocês, né? Está no meio de um feriado. Forte abraço.
Abraço.